Good evening. I am Ilonka Rincon, and I'm the Associate Director of Facilitation and Clinical Skills at Kaplan. I've been with Kaplan for almost 9 years now, and I am now in charge of the part of content for CS. So I wanted to start today going through a little bit of data and some of the problems that we've seen with students, and some ideas about what we can do to help them be sure to be ready for the Step 2 CS. Um, from the beginning, what is interesting is the data that we are getting from the USMLE, and it is interesting that even though in the year 2018 or 2017, or the period 2017, 2018, we had a little bit more test takers. However, the percentage of students passing decreased a little bit. You can see that it's true for MDs, for DOs, for non-US and Canadian schools, and for US and Canadian schools as well. Then we also have the data of the CS exam divided into its three components. ICE, which is the integrated clinical examination part, the communication and interpersonal skills, which is the CIS, and the spoken English proficiency. And we have a very nice comparison between all US and Canadian school and all non-US and Canadian schools. And as you can see, we also saw some decrease in the number of students who passed. Um, Here at Kaplan, we also are doing some research, and in the last year, we were tabulating some of the students, uh, dividing them into the students who have English as a first language or study in English programs, and those who didn't. And this data is on English-speaking students. And as you can see, well, the spoken English proficiency is not an issue with this set of students, but the communication and interpersonal skills is an issue. We can see a big part of the students not passing, and on the eyes part. And then I have also an interesting breakdown of the two components. ICE is the interpersonal and the integrated clinical encounter that is divided into the physical examination part and the patient note. And so we have all the data here for, it's around 300 students that we were taking notes of their development. As you can see, the patient note part is one of the components that they have a lot of issues with, a lot of students being in the borderline pass. Of course, these are things that are very easily arranged and fixed so that the students can perform even better. So I wanted to start talking about standardized or examinations that use standardized patients. Students fail standardized patients for a variety of reasons, and faculty usually is left with the dilemma of how do we help them? There is not a lot of guidance about how to help these kind of students, and often the core problem behind the student failure is never really made clear beyond the fact that the student is not performing at the level that one is expecting, right? The remediation part is always complicated and kind of haphazard, and it's not really targeting the actual problem that the student has. Standardized patient examinations test a variety of specific competencies, and students can be deficient in any or all of the parts. And so these parts can be the technical skills, clinical reasoning, knowledge, based in ability to relate to patients, as well as the documentation, and then transporting that documentation into an actual hypothesis and diagnosis. And so in which part of these is the student failing? It's part of the problem. If we can't specify where the problem is, we can't really help them out, right? I wanted to break down a bit of some of the issues that one can encounter with standardized patient examinations. Some of the issues can be related to the examination per se. Some can be related to global things or standardized patients, and of course the students. One of the reasons that standardized examinations can be a little bit complicated is because we need to ensure reliability, right? And so to ensure reliability, research advises that we do tests that include at least between 10 to 14 cases on high stakes clinical performance examination. And if you have too few of them, then you're not going to ensure that you can see globally how the student is really performing. Sometimes the performance is set way too high. It's kind of interesting because in 1992, I believe it was Kobolo demonstrated that physicians usually set a passing standard that they routinely fail themselves to achieve. It's a very interesting phenomenon, but sometimes that is the case. I've had a couple of instances where I work with faculty and I've asked them to actually perform what we're asking the students to do, and most of them fail, which is interesting. Then there's the SPs involved who are not following scripts adequately, and that even though it's unlikely to happen in all the cases, it can mess up a little bit how the students are performing, because the standardized patients are not giving the correct information, leading to a set of errors that will result in the student not getting to the appropriate hypotheses. Another issue is the examinations typically can overestimate clinical performance ability. If you think about it, standardized patients are tasked with having to give a grade or to grade students, right? What happens when the standardized patients are unsure about how to grade something? They usually tend to be more lenient, and so the scores overestimate the actual clinical ability of the students. Students are sometimes not properly oriented into their role in the standardized exercise. And that happens quite often, where students are not sure what it is that they are supposed to be doing. They don't know how much of the encounter is their responsibility, and they can't foresee how much of the tasks that they need to perform are their responsibilities. And so this is something that is important to pay attention to. And the time allotted sometimes is not adequate. It has to take into consideration the level of the students with the competencies required. It would be unfair to ask a first-year student to perform at the same level of somebody who's a third year. It is obvious that the timing is going to be an issue, as well as how to get to a differential and management, right? One of the things that I think that it's pretty obvious is sometimes the system errors, which is curriculum-wide issues due to unstructured clinical assignments. There's a huge degree of variance in the way students are exposed to patients because they have unstructured clinical assignments. Some students can see multiple variety of cases or a particular disease, and they see several cases of that particular disease, but that's not the case for all the students involved. So the test should try to take into account and have equal opportunity for all the students to see the same amount of patients, the same quality and the same characteristics of patients, so that they are able to answer and perform better. Some of the standardized patients related issues. We've encountered some of these with our own standardized patients. Is the script clear? How much detail is too detailed? Because one of the things with a standardized patient examination is that you want to make a case that gives away sometimes to more than one diagnosis, or the possibility of more than one diagnosis. Do you want to you don't want to be so specific as to close out any other possibilities if you want the students to consider different options. When details are too much, sometimes the scripts can get very, very complicated and prolonged, and so that is it causes the standardized patients problems when they have to memorize, when you switch cases and they have not, they don't have a lot of time to memorize new cases. One of the questions that it's always important to think about is it clear to all the SP when a point gets awarded and when it doesn't? And what happens when there's borderline behavior? How do you score that? So these are all conversations that need to happen prior setting up students and to face standardized patients. Some of the student-related issues, well, obviously, lack of knowledge about what is allowed within the constraints of an examination setting is quite an important issue. I can tell you from firsthand experience, when I had to prepare for the CS exam, I came from an international, as an international medical graduate, and I was not used to this kind of examinations, and then to understand that this was to be treated the same way, and that I had ownership of everything that happened in that encounter was a hard step to make. But once you see the students understand that they're in control of that environment, that they're the ones in charge, then there's a change, and they start getting and understanding what their responsibilities are. Some students, in the case of standardized patients in their schools or like OSCEs and stuff like that, the problem is that they can be camera shy. You know, the situation seems not real. They have a hard time adapting to that. Then there's the checklist-driven examinations, which theoretically decline with increasing clinical expertise. One way of solving that problem is to have content experts reviewing tape performances with global rating scales that might differentiate great performances with bad checklist grades from those who are really not performing well. There's not a lot of data about the prevalence of this, but it has been described before. For the CS specifically, we've encountered a couple of issues that are very specific for the Step 2 CS, and the most commons are timing. Students run out of time a lot, and they're very nervous, and so either they take too long in some parts of the examination, or they go so fast and they think that they did everything, and they exit the room without realizing that there was scope and time to do things that were important for the examination per se. Some of the students do the premature closure. They're so focused on finding what is the right answer, and so their data gathering kind of becomes skewed because they are trying to really define and answer that one question. And so they're unable to really, step back and see what are all the possibilities. And some of the students have the data, have the differential, but they are kind of unconnected, and so they can't really manage to get the patient towards the next step. Other common reasons that I don't think are as specific for CS, but I think are very global is, nerves, language more related to international medical graduates, the same as cultural expectations and differences, and not enough preparation. And some students, I think older students more than younger students, have an issue with typing. So practice, practice, practice. So here's the thing. I think it is important for us to understand where is the problem, where's the student failing, which part of all the tasks and all the competencies that the student needs to accomplish and perform well, where is this student having problems? And I think it is important, because if we don't specify which part of the examination the student is having issues with, we can't address that, and we can't change outcomes in a way that makes sense. So sometimes the students have problems in how they approach the task. They lack confidence. They sometimes, when it's OSCEs related, they don't take it as a serious case. They think, oh, this is just acting. There's sometimes issues with their relationship with the patient. How to um, how to be open-minded and not judgmental about things that are happening with the patient, and trying to give that sort of calm and open and safe environment for the patient so that the patient can tell you things. Sometimes they are struggling with communicating to the patient. They can't summarize appropriately. It's not comprehensive the way that they talk about what they find. Um, it's unclear as to what it is that they're trying to communicate, or sometimes when it's about the patient, when they're trying to talk to other doctors or report their findings, this is poorly conceived or either written or orally. Some of the issues can be with the data collection, that it can be disorganized or incomplete, or with the data interpretation, where failure to recognize patterns leads to wrong interpretation, or sometimes the presumptions of findings. They're so set up on this diagnosis that they want it to be, that everything that they're asking is to fit that sort of mold they already have. And in terms of the treatment and management, they might get to the correct diagnosis, but then the students get wrong the decisions and the next steps that they need to follow in order to treat the problem. So when facing a student that's failing, I think these are important questions to ask. How bad was the failure? Is it a failure of one specific part? Is it a failure of knowledge? Is it a failure of the student relating to the patient? How bad is it? Is it complete? Is it that the student is lacking in all aspects of the encounter? Are these errors across multiple cases, or is it case specific? That gives you an idea of it's related. Sometimes we can go around and talk about triggers and what is in the student's particular case past, and what it is that they can or cannot relate to the patient. Is the student aware of the problem? Sometimes students aren't aware that they have a problem. Sometimes students can appear overbearing, and it turns out that it all stems from not knowing really what to do or how to behave. And the other important question is, how long has this problem been going on? So I've compiled a couple of useful tools that I think can help you ascertain where the issue is with the students. And I'll go over some of the tools that I find that might be helpful. There's the case write-ups, which helps to understand if the student can recognize what are the important elements of a case. Then there's the oral case presentations, which help to see if the student is able to organize a case mentally and present it in a logical way, that is in a way that's organized, that it's compelling, hopefully. And so it gives you an idea of where the issue is. If using the debriefing and stimulated recall, which is when you do an immediate replay of a recorded student encounter, and you go step by step with the student sitting next to you and going over, so what were you thinking when you asked this patient this question? And what were you thinking when you said this thing? And so on and so forth. It is quite helpful because it gives you the opportunity of being one-on-one and trying to understand what the thought process is for the student and where it is that they're making wrong assumptions or errors. And then there's virtual cases, which is a new and emerging new way of using the internet and other media to help the students. This kind of thing, if it's set up correctly, allows the students to work and organize question sets. It organizes the knowledge and helps them prioritize the data and practice these steps before they have to do the interpersonal aspect of it that sometimes creates a lot of issues. I've seen so many students who have the knowledge, and it's not a problem with the knowledge, but they are going through their checklists in such a way that they forget that they're seeing a human being in front of them. And so that relationship is not happening. And of course, then they fail the examination because the standardized patient feels like they were being treated by a robot. And so I think that virtual cases is one of the things that might be the most helpful, because it lets the student kind of prioritize their thoughts, make sure that things are kind of clear and practiced in a way so that then they can incorporate the personal stuff. There's another set of tools like multiple choice questions, which, you know, the usual for testing knowledge. It gives you the ability to sample wide areas of content, and it's, you know, very time and cost efficient. But it doesn't let you see other or recognize other moments where the student is not performing as they should. There's the diagnostic pattern matching. You give students some to match, you know, such vignettes that are sort of organized, and so that they come up with likely diagnosis. There's the clinical data interpretation, which measures the ability of the student to consider new information that is added and seeing how that new information kind of impacts the possible diagnosis and next steps that the student needs to follow for the patient. Then there's the patient finding questionnaires after an SPU interview, and you can double check this information with videos of the encounter if you have them, because it tests kind of like you have the student do a case and then kind of fill up this questionnaire. Did you ask about allergies? And if the student did in fact ask that question, you can double check to see what it is that they asked during the encounter through the videos. And then there are the paper cases, when you give them unstructured information, like both important and non-essential, and the student needs to come up with a clear set of relevant signs and symptoms, and then that they can be used to reach a hypothetical diagnosis. Or there's the symptom pathways flowcharts that help with the pattern recognition. I think a lot of the issues are stemming nowadays from the fact that the way that students used to learn was as an apprenticeship. They were following clinicians in hospital rounds, and that time, that face-to-face time has been decreasing. The clinical faculty have a lot of responsibilities with research or outpatient clinics. That residents have limited times of hours that they can spend in the hospital, as well as students. And so that face-to-face and that apprenticeship is not happening the same way, because what we need at the end of the day is for the students to be able to recognize patterns of signs and symptoms, and to be able to recognize that human beings are also there, so that they can create that kind of relationship that will help them not only ask the right questions, but get to the right diagnosis and follow through with the correct set of steps for management or treatment. For the Step 2 CS passing, there's not just one right way to pass Step 2 CS, but rather many ways. This exam is largely about applying common sense alongside medical knowledge in a situation that is very dynamic and changing, and so it's very reactive. And it's that is the part that is sometimes really hard to teach. How do you teach common sense, right? And so I think that it requires a level of comfort with the exam, all the parts of the exam, so that you can rely on that when you're nervous. And I think that kind of comfort comes from practicing. So I am going to stop now, and I think we'll have questions towards the end of the session, and I'll pass it on to Brent.
Yes, no, thanks, Alaka. Thank you so much, everybody, for joining tonight. As she described, we are going to be answering questions at the end, so we have plenty of time, and I'm going to run through a couple things. But I just wanted to introduce myself. I'm Brent Thaker. I am your strategic sales executive for iHuman. I've been with Kaplan for just over 14 years, and I've been in the institutional side, selling to institutionals, medical schools, family practitioner, nursing programs, also PA programs as well, DO, and undergrad nursing. So I have a lot of experience, and what I'm going to do is we're going to introduce you to iHuman tonight. iHuman has actually been around for just over 7 years, dealing with the virtual simulation and patient encounter. And Kaplan acquired iHuman roughly back in February of 2018. So we are now merging together as another opportunity and tool to partner with programs such as yourselves out there. But I just want to kind of give you a quick little background, showing you what iHuman Patients is. It's a competency and knowledge assessment tool, and also provide you with individual and aggregate data. Within the program, there is several opportunities, and what it's ultimately doing is basically creating that flight simulator feel for your students as they're learning and building, assessing their cognitive skills and development when they're developing those clinical and diagnostic reasoning skills. So it's ultimately measuring competencies and making sure it's also able to track what's going on between their ears, which is very hard to do, and it's also eliminating when you're dealing with standardized patients as a format of training your students. It's now eliminating human error factors. We have an extensive standardized evidence-based feedback for the programs for students so they can self-learn. It's a self-remediating tool. I will show you what this looks like, but there are different modes of play. There's a true assessment test play where they just go through and get zero feedback until the end, or we have a learning mode, which 90% of our partner schools do open up for their students, because it's like having a preceptor or a faculty member along with them as they're developing and learning when you can't be there. So these are assigned again in multiple facets of ways, and also, and again, enables you as faculty to assess both individually and aggregately. So as we come in through here, how we're doing that? Well, we're doing it through a typical full standard patient encounter. You're going to review medical records if they're there, talking about taking a history, walking through and assessing and taking vital signs, and performing, interpreting, physical exams, creating your differentials, ordering tests, etc. What I'm going to show you tonight is a sample of one of our OSCE. We actually have a specific OSCE case that we've developed. We have several of them, in addition to hundreds and hundreds of other cases and symptoms. We literally are in the hundreds of avatars. So we literally go from a 2-day-old all the way up to a 95-year-old. So along this program, it can be scaffolded throughout your full curriculum from day one of medical school all the way even to the 4th year through clinical rotations. So I want to kind of show you this real quickly, how we've set up our OSCE specifically. And again, these are all added in. I've added special notes. You as a faculty member would have instructions for your students to go through. But we have a chief complaint here with our patient is Enrique Santos. Chief complaint is body aches, fatigue, feeling feverish. So we would step in and we would actually provide them with a pre-test, kind of setting up what are the components in the Step 2 CS exam. What is it that they're being evaluated on? We provide that information, go through here as a learning. They have 15 minutes for the patient encounter. They have 10 minutes to write a patient note. So it's ultimately, we are simulating that full experience of the Step 2 CS. As they go through here, the more tips for the communication with standardized patients, again, allowing students to get prepared, get ready to go before they jump in. We then provide kind of a quiz. What do we know we need to do just to kind of get them set? We're creating a tool, or I shouldn't say creating, we've created a tool to truly build up that confidence and get them, so it's not that they're worried about how to interact with the patient, or not that they're worried about what questions to ask. They're truly getting that more comfort feel that when they knock on that door and they enter that room, they have the full confidence of what they need to do and what they need to go through. So again, this is in a learning mode. I'm giving feedback along the way to make sure I know what I'm forwarding and going through. You're just going to do a hi, I'm Dr. Baker, which there's no way that I am. However, you just evaluate, see what would the expert feedback say. And again, what do we make sure the 2 options listed here, best phrasing for questions, do you have any other symptoms versus you don't have any other symptoms, right? So we're trying to teach them to get them understanding what they're trying to do as they come through here. Again, multiple choice. here question. I'm just going to say use open-ended questions. Let's say I want to, hypothetically, I'm going to add some ones that I know they're wrong. And so I'm going to get an evaluation. Again, I got 0% because I just missed the one. I added the one that shouldn't have or two that shouldn't have. I missed out on these. So again, we provide the full discussion, remediation, and we haven't even talked to the patient yet. So this is setting up. We are now ready to go in. We start and jump right in, and right before we have the doorway information. So you can see opening scenario, Enrique, 22-year-old graduate student, presenting complaint is sick, get some vital signs, examining tasks, obtain focus history, et cetera, et cetera. So now I'm here, I'm ready to go. I start talking to my patient, and you may or may not hear some extra breathing. That is our patient. He's blinking, he is alive. You can see his chest and shoulders kind of moving. It's kind of a general appearance. And we jump right in. I'm going to mute him because on my end, the speakers are loud, but I'm sure it's hard to hear with so many of you coming in. So we have multiple ways of how we can ask questions. Within our system, we have roughly a pile of about 3,000 questions we've embedded that they can pull from. As students come in, they are learning, how can I? And as you see, as I'm typing, there are questions that are kind of pulling up like a Google search. What is it that I'm trying to find and do? How can I help? As I'm getting more specific, that's where I'm looking for. This is the question I want to ask. How can I help you today? So you ask your patient, well, I feel awful. I'm exhausted, ache all over, and feel like I might have a fever. We provide key findings area on the left side so they can take notes. So we know that he aches, if I spell right, and he says might have fever. I'm going to make a note of that. And we can continue to go forward and start asking more questions. We can even do any other symptoms we should be concerned about. So as this is populating back, I find my answer and any other symptoms or concerns. Oh, he's got a sore throat. Sore throat. And he has a cough that we want to now examine into. As I'm learning, if I am not experienced, if I'm learning old carts and understanding what is it that I need to ask my patients, we provide a hand-holding. You as faculty can turn this on to your students and give them a taxonomy of statements and questions to utilize. I'm going to screen down this here real quick so you can see the full categories. We have interviewing openings. I've used a couple of those. We can talk about diving into any constituent complaints if he had them. He's specifically talking about cough. So I can pull up anything that has to do with cough, if I pull up the right piece. So cough, here's all of our questions that we would have under cough. When did your cough start? I think yesterday. What is another important question? Are you coughing up any sputum? No, it's definitely dry. Okay, well, I want to make that note and just say it's a dry cough. So I can go in and continue to add my notes. If I want to, I can start coming up with differentials along the way in my mind, and I can make a document and add them in and say, you know what? Maybe he has the flu. If I know how to spell. And I'm going to pull up my flu. I'm going to add that to my diagnosis. I don't know if it's my lead or alternate, so I'm going to come back to that. Again, continuing to go through step by step, asking questions. Again, we stay with the cough. We could ask, how bad is it? It's just annoying. It makes my throat really hurt. So again, this tool is designed, we can scaffold these throughout. We can have the level of play of difficulty. I've actually set a limit on this particular case to 60 questions. We can undo a ceiling. We can see how the students are actually going at it. I think this particular case is 21 key questions I'm supposed to find throughout this history taking. But as I'm going through and say if I got stuck, well, you as faculty can actually say, hey, you know what, we're going to throw our students a little bone and give them a hint. And what the hint's going to provide to them is saying, hey, you've asked 4 questions that are key. There's still 18 out there that I'm missing. But instead of telling them what questions to ask, I'm going to guide them and say, hey, look, there's 8 questions in associated symptoms. There's one in history, past medical history is 4, social history is 1, etc. Review of systems. So again, you can go through, and find out review of systems. What do I want to look at? Respiratory. We've already talked about the cough, etc. So all of this is now interplaying with the students. As I've come through and maybe say I've asked all the questions I wanted to ask, and just for the sake of time tonight, I'm going to move forward. We can go now into our physical exam. So once we have completed all of our questions, we made some notes. I'm going to go in here and start taking maybe his pulse. If I am also in the learning mode still early on, we can actually add in the hotspots. So again, reemphasizes, if this is more of an assessment, and hopefully you can hear his heartbeat, but we would keep them off to truly get the sense of, are they able to pick it up, etc. So I would annotate and make notes. I'm going to make a note that he's at I don't know, 110. I did obviously listen long enough. Every click that I'm doing, iHuman has created the tool that we can actually, and we can listen to him cough. When am I doing it correctly? It's now black and white. This tool is assessing, do you hold and count long enough? And there's a clock that's going through here. So under respiration, maybe I'm going to say it's a little bit labored. I'm going to say it's irregular, maybe again labored. We want to take his blood pressure. We can blow him up here, check him out. You can hear him coughing now. Did I blow it up high enough to get an accurate reading, etc.? Do I let go of the needle too far? Oh, shoot, I forgot to do it, but maybe it's normal, and I'm just going to make sure it's normal, and I'm going to just type in a number here and maybe I think that's right. Again, I'm going to mute him. We can do a full head-to-toe assessment. So if we are going in here and we want to inspect his eyes, we would see eyelids, no conjunctivitis, pink, no discharge. I want to test his visual acuity. If I want to perform an ocular motor test, here again, I can actually perform this. I'll blow my screen up a little bit, and you can see him follow my finger across the screen. Am I doing it correctly? Am I doing it too fast? Am I making him dizzy? Ultimately, at the end of the day, you have the full capabilities of doing what most psychomotor teaching is going to give you. We're trying to present that here in a virtual simulation world. So again, I have looking check reactivity. I have a flashlight looking for any reactivity in his pupils, as you can maybe hopefully see. He does have some normal reactivity, which is fantastic. I want to look in his throat. And so I typed in throat. Well, that's not what you're supposed to do. What if I want to inspect, what am I doing here? Perform, look in ears. I can test his ears. Has normal light reflex. I can look, inspect nose. I want to inspect his mouth. And here's what I was looking for. This is, I'll show you full screen. I can blow that up. I can get a good shot in there. You see clarity as more I zoom in, it is not leaving. It is actually staying and getting more clear. So we can see he's definitely got some issues here. It looks a little irritated. So again, I can add more notes, make all these key findings, etc., going through, adding another differential along the way. And then also within the program, we have embedded exercises. So not only have I done the exercise to get in, we can also provide another exercise here. I'm not going to complete it, but as I move forward, now I want to get my clinical feedback. Here is now having that learning mode really kick in. So we're simulating this whole experience. And again, now you get full feedback. I've asked 5 questions, 4 were on the money, 1 was out in left field. So our goal here, obviously I would be asking more questions, but for the sake of time tonight, I'm just trying to show you kind of what and demonstrate what this does. As you can see, we're providing what were the key questions that they should have asked. We can also go back and ask the questions again if we really wanted to. So we can go through here, get the feedback, remediate. It's even tracking again the order of questions, what I did correctly, what was incorrectly not required by the author, etc., or inappropriate. So even though I'm now also taking history, it's also documenting my vital signs. Did I document correctly? Did I find it, all the information? I did look in the pupils, all was good, H-test good, correct. I did a couple things. What am I missing? 3 key exams. I forgot to check his chest wall and lungs. I didn't auscultate as long as I should have. I performed 5 exams that weren't required, but then I also performed exams that I did, but I did incorrectly. So I didn't count for the minimum 15 seconds to validate his heart and rhythm. So again, this full tool is what you go through here. Now we're going to go to the assessment mode. I'm going to identify my key findings. I'm going to say sore throat is my key findings. All these others are related, maybe with a dry cough. I'm going to get my clinical feedback. Again, identifying what is it that I should have found based on the case author expert. Should have found a fever, does have a cough, body ache, sore throat, headache, fatigue, etc. We write our problem statement. Here you can say Mr. Santos, etc., etc. Get some feedback on what that would look like. Again, we have 155 characters that we can complete that in. We now are selecting our differentials. I had influenza carry over with me. Maybe he has strep. So I want to pull up and make sure that he has strep throat. Maybe I thought he had pneumonia. And so these are my guesses of what I think for differentials. On our OSCE cases specifically, less on the how many different differentials there are. On our traditional full plate cases, LADU goes through the same processes, but can have multiple differentials. So I'm going to get my feedback. Here we're going to click and see that I was right on the money with 2, but I forgot about pharyngitis. So why did we missed it? Why is this key? It shows you what are all the signs that I should have found that fits into this diagnosis for a differential. Now I'm going to rank my differentials. Based on what I've found so far, I'm still just going to say the lead is just the flu, but he might have strep, he might have pharyngitis. A must not miss is something that we want to make sure we don't miss, because if we don't rule it out, we could lead to serious complications down the road. I know strep throat specifically is something that I don't want to miss, but hypothetically, what if I thought pharyngitis was one too? And so we get feedback. Ultimately, what is correct, what is incorrect. Again, full discussion around Enrique and what all the protocol is that we are doing from here. Now I can select my tests. So within tests, you know, if I know what I'm looking for, I want to do a nasal swab, hypothetically. What if I wanted to rule out, maybe if I thought he had pneumonia, I wanted to order a CBC. Oops. And I want to order CBC, and I'm just going to put that as a generic test out there just to rule it out. If you don't know what tests to order, we do provide a full, again, catalog that they can go through. And again, the searchable function here, again, it just defaults what we have. Lots of tests. Again, what's important tests? Are they not important? There are better tests than others. And again, we wanted to probably order strep, but I'm just going to show for the sake of time, walk you through. Lo and behold, CBC, nope, I should have ordered the nasal swab. I didn't actually select it. And then the rapid strep. So we should have identified these. This is what was missing, and again, what was wrong. And then we're going to go into our review test results. So this is, you know, very basic case that we're talking about. It's influenza, testing positive, and for strep, he actually tested negative. We do have other cases here that we can show. This is an endocarditis case where we have, you know, we've ordered a lot of tests. We can see from the echocardiogram, we got a nice little flap going. We can see from the Doppler here, you know, there's leakage. Full interpretation of what we're seeing. Chest X-ray, again, with that medical media, I wanted to show you, like, we're zooming into medical documents and media here that we're not getting a loss of clarity. So I just wanted to show you kind of another example of what we can see, how full go this program is. We then go in, we're going to make our diagnosis based on our 3 differentials, get our feedback, and again, full discussion here, and then open it up to writing our management plan. So writing a note, SOAP note, etc., whatever you're trying to require them to do. Again, get the full clinical feedback. Expert patient notes, here it is. This is all just kind of a baseline of where the students should be getting their information from. Once they submit and review for a case summary, it will show like, hey, you didn't do all those embedded exercises. For sake of time tonight, I'm going to skip those and just take a 0. But you could see all of the key learning objectives. What is the patient disposition associated with this particular case? All the history taking strategy. We are providing them the old carts and what are the questions that we should have asked and the response in addition to the information that we take with that. So full go, full remediation, allowing students to truly get more expertise. And again, thinking of, we have hundreds and hundreds of cases throughout as they're learning their didactic years into their clinical rotation time, also filling in gaps. We have different categories of all different types of patients going through here. Once they have gone through and they want to evaluate, they do a full self-evaluation, but for faculty as well, we do have the ability to track. We can actually set up a rubric for you, creating a mastery level of competence. You as faculty would work with us and our implementation team, which is an academic team and support team. You can set a competency level of when they're doing a history required. Yeah, they found 90% of the right answers, but look, it took this student 264 questions with a 15% accuracy rate. We need to dial this student down. Yeah, they're getting all the right answers. However, it's taking them a long time. They're going to kill the patient or the patient's going to kill them before they get their results. And we can also put in the weight factor to help you with a scoring rubric. So for this particular sample, we've weighted history and physical examinations at 15% each, but the differential's at 30%. So we can actually, at the end of the day, create a full scoring rubric to identify your cohorts more aggregately, individually, who's having issues, who's not. We have a lot of point graphs. We can dive into specifically what are the misses within your cohort, what are the extraneous tasks they seem to be caught up in doing and handling. So with that, I can spend more time, but I really know that there's a lot of good questions out there. So I think I'm going to open it up here and kind of conclude my time and stop sharing my screen and just open it up for the full world here. And you can ask myself, you can ask Alanka, what you guys have out there. And so I think one of the first questions came in, Alanka, did you see, I don't know if you have the chat up, but it says, I'm new to all this, but are students typically taught to develop a differential diagnosis during the encounter or only at the end of the encounter? And you're gonna have to unmute.
Right, thank you. So this is a great question, and I think there are different schools of thought about this particular question. We like to tell our students that they should start thinking about differentials as they, from the moment that they're starting when they see the note at the door, it already starting to, kind of decipher what it is that they're going to be asking, because having a sort of a list of differential diagnosis does help when you are, when you practice a lot. It does help to sort of guide what kind of questions you're going to ask next and what kind of information it is important to elucidate. You're not required to have the differential from the get-go, because it is towards the end when you're writing your patient note that you're going to write 3 or more differential, 2 or more, depending on what you have, and prioritize them according to which one is more likely or not. But yeah, so it depends on how do you want your students to start thinking about the information. There are different approaches to that. And I see another question. Step 2 CS penalizes for unjustified diagnosis and unnecessary, costly, or invasive testing. Do you think this penalty can be severe enough that it serves as a reason for failure? Well, I don't know, because I don't see how it is that the USMLE is actually grading or not grading, but I find it hard to think that you would be horribly penalized to the point of not passing an exam just by ordering things that are unnecessary. I think they do take points away, but I think it's like a cumulative thing, depending on all the rest of the things, how you're doing. It's going to cost you more or less. It's hard to tell.
Great, and I see somebody pointed out that the simulation department reviewed this platform, probably iHuman, a couple of years ago. Memory serves, it was a very significant financial commitment. What is going on with subscription at present? So great question. So I'm happy to, if you guys want to submit any information, we're happy to set up a full demo, dive into the full program. What I showed you was one of our OSCE cases. We have a lot of traditional cases, and then we also have what we design as symptom to diagnosis cases.
Yes.
Those come for full-fledged, again, scaling, how we can use those and create the use of that. We can create our cases just be H&P only. We can have H&P plus diagnosis, but we can scale it all the way through where in our advanced play and symptom diagnosis where they're actually able to order tests while they're taking history. So full simulation of live encounter. The pricing, I would, it's probably changed several times since we've last, you've seen the program. Basic starting price, just to give you a sense, the lowest point is roughly about $100 a student per semester of use. We are literally just creating packaged pricing where we are looking at an M1 package, an M2, M3, or M2, M3 combined, even M1 to an M4 package. So once you start to divide the packages over time, and we're giving you a major discount, so the students are actually incrementally paying. So again, highest point at this point right now, we're looking at roughly $1,100 is our full in, all in, probably inclusive to the program from year 1 to year 4, all the way down to $100 per student per semester. If it's 8-term program, 4 terms, if you only did it for the didactic years, clearly you can see what the difference is on that. But happy to get more specific, dive into what your needs are. We can give you a better accurate quote on that. But good question. What are any other questions you guys have for us out there? We have quite a bit of time, which is exciting to answer.
I don't see any questions coming up.
Yeah, I'm not seeing any either. Oh, here we go. Is it expected that in the 15-minute time frame of the encounter, that the student will cover the patient's entire medical history? Could be super. Complex, e-travel, social, sexual history, extensive, etc.
I think this is, if this is related to iHuman, or is this for CS? Because if it's for CS, this is where we teach our students how to be more focused. Obviously, depending on what type of case you're having, what does your patient have, you're going to spend more or less time. If this is an acute case, like an emergency type of things, and appendicitis about to explode or whatnot, then you obviously are not going to take a long time to ask them about great-grandparents and their aunts and stuff like that. If you have more time and this is more of a mental health issue, then you probably are going to have to spend more time doing the social things. And I think that's one of the cool things about iHuman is that it gives the student different cases and different ways of prioritizing the information and kind of working through the different sets that they need to figure out for when they're actually in front of a patient. Do you have anything, Brent?
Yeah, no, and that's, I would say, very similar, depending on the level and where we're introducing cases from iHuman. Early on, when they're learning it, and in their first year, maybe their second year, it's going to take a little longer. They want to know exactly what is it they need to ask. They don't know all the questions to ask, but they ask everything under the sun. As they develop that. So again, the program is designed, I would say, as they get to the knowledge base and are ready to really interact with patients. The average playtime for our cases is roughly anywhere between an hour, hour and a half, depending on what the symptoms are, what the diagnosis could be. The more complex, we have well visits. Those take very short amount of time. It's just kind of a checkup, etc. But then, like I said, I showed you a bacterial endocarditis case. That was just 42 required questions that you're supposed to find. You don't realize that, he's presenting with just fever, aches, then all of a sudden you find out he has rashes. Well, then, lo and behold, he's also an IV drug user. So there's a lot of findings, history, social that you have to spend finding. It's going to spend longer. It's not a typical OSCE case. That is a typical, more diagnostic case that we're learning the skill sets along the way. So I think that's kind of where what the whole program is designed to do is interact, introduce early, all the way scaffold throughout, and then truly use as supplement into the clinical time where they aren't getting enough PEDS cases. We have PEDS supplementals. all of that type of background for them. So another question I see is when you are counseling a student who has failed step 2 CS, do you have a strategic line of questioning to help isolate the issue?
Well, that is a good question. In general, we are not necessarily doing remediation just yet with students as per se, but we do spend a lot of time talking to students, trying to understand what it is that is causing their issues. And so there are a couple of things that one can do to assess where it is that the student is failing. Is it a problem with knowledge? Is it a problem with nerves? Is it a problem with the tasks required that they don't understand how things are supposed to work? So we have a set of questions and things that we can ask the student and see. Usually when they come to us and they've already failed, they usually show us their score. And so we can tell if this is a problem with their spoken English proficiency. Then we have a set of things that we can suggest for them to do. If it's the integrated clinical encounter, then is it a problem with the patient note? Is it timing? Is it typing? Sometimes it's a problem. Or is it a communication thing? And so we have a set of things that we can help them with. But we're working on this as well. I think there's another question for you, Brent. How can a faculty member take this course to help students at Institute?
Sure. So again, if you are interested in setting up a demo with myself or my colleague, Beth Johnson, depending on where part of the United States you're in, ultimately, if you go to i-human.com, or you can send me a direct email as well. My email, I'll spell it real quick. It's Brent, B-R-E-N-T .Baker, and it's T as in Tom, H-E-A-K-E-R @kaplan.com. Just send me an email or send it, go in through inquiry through our website, and happy to set those up and coordinate a demo. Demos take anywhere from 60 to 75 minutes, depending on how in-depth and questions we want to get to. But from there, we can set up a trial account that you as faculty can actually play with it a little bit, get a little bit more conversations. How we want to maybe implement that, we can have an academic conversation as well. So several steps, but it's very quick and easy to skip. Great. Anything else that you guys, can think of as this crowd is winding down? I'll first of all say thank you again all for joining. It's, for some of you, it's middle of the day. For some of us, it's also getting into the evening hours. I'm based out of Columbus, Ohio. So, I'm East Coast time. But we're all over. Kaplan is global. We're worldwide. iHuman is, we have a lot of support in California, but we're all based all over the place. So it doesn't matter what time frame you're in, we will definitely make a time for you as well. So any other things before we conclude and move forward? Any last questions out there? I do have one that says, you mentioned practice, practice, practice. Are you suggesting that students do this on their own? If so, how do you suggest they do this most effectively, since they won't be getting expert observation or feedback?
That's a great question. I think there are a variety of ways that, it will depend on what level the student is in and what part of their preparation they're at. Because if this is a student that's just starting and they're not really preparing for CS, I would not recommend they do this on their own. I think they need all the structure that they can get to get them into the right path. If this is a student that is already done some of the practice, we offer a lot of different things that they can use to practice. There's also, our lecture notes towards the end when they're about ready to, and they need to practice with their classmates or friends, where we actually give them not only a case scenario so that they can practice, but we provide them with checklists and patient notes for that specific grade so that they compare to what they're doing. So there are many different ways of practicing, and it will depend on what stage the student is in. From the beginning, I would not recommend that they do this on their own. I think they need to have the structure.
Yep, and I'll one last plug for iHuman patients. that's what I was describing and walking through about having the expert advice as along the way as they unfold as they're learning. So it is a tool that we are designing or have designed to really help fill in the gaps of not having a faculty member or preceptor or an SP with you. It's a way cheaper than an SP encounter as well for feedback because we're providing that expert feedback along the way. But with that, I know we are right at the point of the hour. So again, thank you so much for joining us. Happy to answer more questions offline, send us emails, etc. Love to set up anytime as well. But thank you so much for all your time and commitment.
Thank you.